I will be presenting today on is PrEP associated with bacterial STIs among gay, bisexual, and other men who have sex with men, or GBM. PrEP and sexual risk behaviors in Montreal, Toronto, and Vancouver. I'm presenting on behalf of the Engage Cohort Study Team. These are my conflict of interest disclosures. PrEP, or pre-exposure prophylaxis, is a proven biomedical intervention to prevent HIV acquisition. Risk compensation, that is, an increase in STI or HIV risk behaviors, may be occurring as a result of increased confidence in the protective effects of PrEP. However, bacterial STIs such as syphilis, gonorrhea, and chlamydia have increased among GBM in Western countries since 2010, including to some extent in Canada. The meta-analytic findings don't show right now that PrEP use is associated with increased STIs among GBM, but most studies have recruited clinical samples of people presenting to HIV and STI prevention clinics and not community-based samples. We're therefore using the Engage Cohort Study, which is a mixed method cohort study of recruiting from the community conducted in Vancouver, Toronto, and Montreal. Our data were collected using respondent-driven sampling, and we recruited cisgender and transgender men that were 16 years of age or older who reported sex with another man in the past 6 months. Our participants completed computer-assisted surveys and biomedical testing. I'll be presenting data from our baseline sample, which is 2,449 guys, and you can see here the breakdown by city. Our recruitment period was between February 2017 to August 2019. We examined in this study the associations of PrEP use with any syphilis, gonorrhea, or chlamydia diagnosis, and the outcome was STIs diagnosed from the Engage nurse-administered testing at baseline. For this testing, participants completed a venous blood sample permitting serological testing for syphilis. These tests were done according to provincial laboratory algorithms, which are similar across 3 cities. A history of recent syphilis infection was based upon a positive anti-treponemal antibody test and a rapid plasma reagent RPR titer of more than 1 to 4, or if the RPR titer was 1 to 4, a reactive TPPA or other treponema specific test, or a self-report of syphilis treatment in the past 6 months. Study participants also provided urine, pharyngeal, and rectal samples. Screening for chlamydia and gonorrhea was done using NAT or culture based upon provincial testing procedures. Due to provincial differences for rectal and throat samples, half of the participants in Toronto had a culture and half had a NAT, whereas in Montreal and Vancouver, all specimens underwent NAT testing. For gonorrhea and chlamydia, any positive result on a urine, pharyngeal, or rectal specimen was coded as a detected infection. For this analysis, we coded each STI, gonorrhea, chlamydia, and syphilis, as either no or yes, not detected or detected infection, and we calculated a combined any STI variable if there was any significant or if there was any detected recent infection of gonorrhea or chlamydia or syphilis. For the present analysis, we fit a structural mediation model with weighted least squares means and a variance adjusted estimator. This model examined associations between any PrEP use in the past 6 months, any multiple sex partners in the past 6 months, any condomless anal sex in the past 6 months, and bacterial STIs diagnosed at the study visit. For our structural mediation model, we estimated the direct and indirect paths from PrEP use to STIs via condomless anal sex and via multiple sex partners. The structural mediation models were adjusted for age, race, ethnicity, income, relationship status, sexual orientation, city, and recruitment-related clustering. Of the 2,000 self-reported HIV negative guys or guys who are of unknown HIV status, 18% reported using PrEP in the past 6 months, P6M, past 6 months, and 17% were diagnosed with a bacterial STI. The initial model without condomless anal sex and multiple sex partners demonstrated a direct effect of PrEP use to STI diagnosis. But in the mediated model, the direct path from PrEP use to STIs was non-significant. There were indirect paths though, and one of the indirect paths was significant, which was the indirect path from PrEP use to STI via condomless anal sex. The pathway from PrEP to STI via multiple sex partners was non-significant. Taking a look at the structural mediation model, this kind of presents what's happening in the figure. You can see on the top pathway from PrEP use to any condomless anal sex to bacterial STIs, the pathways with the red arrow were statistically significant. So direct associations between PrEP use and any condomless anal sex and any condomless anal sex to bacterial STIs. But the pathway at the bottom was not associated, was not statistically significant pathway from PrEP use in multiple sex partners to bacterial STIs. In summary, PrEP was correlated with a confirmed diagnosis of bacterial STIs, but there was no direct effect when controlling for CAS in multiple sex partners. There was the indirect effect, though, accounting for about 13% of the variance in bacterial STIs, was that pathway from PrEP to bacterial STIs via condomless anal sex. These findings suggest that bacterial STIs might be associated with PrEP because of condomless anal sex, but not necessarily because PrEP users are more likely to have multiple recent sex partners. These are just baseline data, so we cannot determine causality. So even my use of language for direct effect is statistical language, but there's not actually a direct effect involving causality. These are associations in the model. We also need to examine if the CAS or condomless anal sex was in the context of treatment as prevention or undetectable viral loads. We should point out, though, that men may be successfully preventing HIV, but they could still be at risk for STIs. We also didn't necessarily assess whether the STIs were always recent. We assessed whether they existed. For future directions, we will examine what proportion of the variance in STIs is accounted for by PrEP over time. We will also examine PrEP's association with individual STIs and potentially PrEP's association with STIs at specific sites like oral or rectal. In conclusion, PrEP may be associated with bacterial STI diagnosis partially because of the greater likelihood of condomless anal sex relative to guys who do not use PrEP. These results underscore the importance of providing counseling to PrEP users about condomless anal sex and its potential role in incidence of bacterial STIs. Condoms might be still useful to mention. Even though they might not be always popular for PrEP users, they will reduce STI infection during anal sex. We also need to be thinking about ongoing efforts to test PrEP users for bacterial STIs and testing and implementing bacterial STI PrEP and dual PrEP for STIs and for HIV. We'd like to acknowledge our many community partners who helped us with data collection and to spread the message in our community. And also, of course, a big thank you to our funders, our affiliated universities, and a big, big thank you to our engaged participants. Thank you very much.